Good morning, everybody. Thanks for coming and for being on time. In order to make sure we all have the opportunity to have lunch, it's my pleasure to welcome you on behalf of Eric Ducasse and myself. I'm Isabel from Belgium. Alison Holliday, who's one of our co-moderators and animators. And I will leave the introduction to Alison.
Thank you. And of course, Eric is here. He's gone somewhere. Oh, there you are, Eric. Very good. Okay. So it's my pleasure to introduce Nacho, who's from Madrid and who's going to tell us about choosing the best access, the Achilles heel. Please, Nacho. And we'll keep strictly to time.
Okay, so I opened the fire today. I have a case. I have a case to share. And this is the case, which is not a carotid. Okay. Okay, it's not a carotid, but maybe I can ask a question. This is the pre-case planning standard for an EVAR. You have plenty of measures, lengths, plannings, and things to do before you treat the case. And I would love to ask you, ladies and gentlemen, have you ever performed an elective EVAR without previous imaging of the aorta? Have you ever done that?
Can we have a show of hands, please? Anybody who's done that? No. Okay,
No.
Great.
Okay. So, Isa, could you ask the people the question? Because I want to look at them, at their eyes,
Fantastic.
to make sure they tell the truth.
So have you ever performed an elective carotid artery stenting without previous imaging of the aortic arch and the supraortic vessels? And those who have, please do raise your hands. Thank you.
Yes.
A few. I'm a sinner. I'm sorry. I have done it many times. Now the real case. It's a 69-year-old female with hypertension and dyslipidemia, left carotid body tumor, which was resected 40 years ago. Big surgery, big surgeons, big incisions. High energy postoperative irradiation. A known left ICA stenosis, which is asymptomatic, and was put under medical treatment. That lady comes for another evaluation because she had a stroke, minor stroke, partial recovery, and a clear progression of the plaque. And I think we have to treat this lady. Any comments? We should go for it. Agree?
Who will treat the patient?
Who will treat
audience?
this patient? Who will? Most of us will.
Right.
Who will not?
Who will not?
Who say medical treatment? Okay.
Okay, let's go. So maybe we should have a discussion, a team discussion, talking about pros and cons of surgery, pros and cons of stenting. And if you look to guidelines, the imaging requirements for both techniques are different. You could perform an endarterectomy just with an ultrasound, or at least 2 ultrasounds, but you should have more imaging for carotid artery stenting. Here it is, an MRI. Nice one. Before we discuss the case, I would like to make 2 comments, because I know what you're thinking about. Nobody wants to open this neck. Agree?
No.
Nobody.
No, you're wrong.
I'm wrong?
Also, depending on the quality of the skin, and the sub-skin, there's also missing the imaging of the neck of the patient.
It is, and it's something we should evaluate with ultrasound. Absolutely. If you take into account the measures you can have with a CT or with an MRI, remember all the measures you have is with the patient in this neutral position, but if you measure with ultrasound, you could turn the neck and try to mimic the surgical position to evaluate all the options. Remember, a difficult CEA is not always an easy stenting. It's not. And carotid artery stenting is not just one single option. The access you choose, the neuroprotection strategy you use, and the stent you're going to implant will definitely impact your outcomes. Whenever I talk about access, I have to show this slide. think about the destination. Think about the 3 different routes we can have: transfemoral, transcarotid, transradial. And if we talk about access, which is the main topic of my talk, this is the recommendation of the guidelines. So if you're considering stenting, you should think about transfemoral, and maybe, if it's difficult, you should consider transradial or transcarotid. For me, this is like, okay, transfemoral stenting is like your partner, lifetime partner. Maybe you can have an open relationship and eventually date transradial or transcarotid. But it's like transfemoral first and then the others. I really think the discussion is deeper. Do we know what makes a carotid artery stenting patient difficult in terms of access? Do we know that? Maybe? Any suggestions? Any thoughts?
Should we ask the audience?
Why
I'm
not?
sure there must be some people.
Barbara has something to say.
So I guess we just need to read CREST 2, and then we know whom to select and whom to not select for transfemoral CAS.
It's a good reading. It's a good reading. And indeed, we do know what makes a patient difficult. We do know what makes a patient difficult. And I would like to focus on that and split the discussion into the 3 routes we were trying to describe. Transfemoral route, which is the longest way, the classical way. We have this classical paper from Sumara MacDonald, our friend, describing with a high impact consensus which kind of lesions are difficult or which kind of anatomical features make a transfemoral patient difficult. We could split this into 3 headlines: access, arch, target vessels, and we could have as many features as you can see in this slide, but focus on the arch ones, because the arch ones has been directly related to an increase in brain embolization. I don't like that in my patients.
Nacho, it's not arch 1, it's arch 3.
It's arch 3?
No, this is arch 1. I think arch 1 is not related.
Sorry.
I'm sorry.
Come on,
it's
Issa, don't criticize me.
I'm sorry.
Second route, transradial, transbrachial. It has always been there, mainly in the neurointervention or the cardiologist settings. We have this paper showing us, again, which anatomical features are related to complications. And it's all about tortuosity. It's all about the angle between the innominate artery and the left common carotid artery. And indeed, in this data, they relate these features with an increase in the conversion rates and complications to the patients. And let's talk about the third one, TCAR. You know it's my favorite. But it also has requirements. A good patient for TCAR needs at least 5 centimeters from the clavicle to the bifurcation, needs a quite healthy common carotid artery, and needs an artery of at least 6 millimeters. And this must be evaluated using ultrasound plus CT or MRI. Why is that so important? Because if your common carotid artery is acceptable, then your access will be straightforward, then your arterial sheath will be stable, and then your flow reversal will be constant and robust through the procedure. The painful truth, ladies and gentlemen, is in your practice, in my practice, in our practice, most of our patients have anatomical features that make one or at least 2 options maybe contraindicated or at least less desirable. And we need to discuss that. We need to make sure before we treat a patient which is the access, the best access, which is the best route to treat the patient, and plan for potential complications. Because it's our duty to select the best procedural option for our patients. Do I have time to finish the case, guys?
Of course.
Perfect. So the case. Let's go back to the case. I don't like the neck. The neck was like this. But if you look to the MRI, you have a bovine arch, you have a short left common carotid artery, You have disease in the external carotid artery, which is not crucial, but it's there. You have tortuosity in both subclavians. You have a really small angle of insertion between the innominate artery and the left common carotid artery. And we have already decided together that we need to treat the patient.
Maybe we may proceed by elimination.
Let's do it.
First, TCAR. You think
TCAR.
this is a good option for you or not?
Should we ask the audience?
Of course.
TCAR is a good option. It's a very low bifurcation indeed, and I told you the requirement is at least 5 centimeters from the clavicle to the bifurcation. It's a low bifurcation.
I actually, Pirkka Helsinki, I actually have a question. Is the image good enough to evaluate?
So, say it again.
The image, is it good enough? I mean, we use CTA routinely.
I think it's, in order to make a decision, to see the arch, to see the configuration of the origin of the supraortic trunk, maybe it's not perfect, but maybe you can use it to make the decision. We could repeat it, but probably the information will be probably the same. It's a low bifurcation, it's a bovine arch, it's quite a difficult angle. TCAR, seems like we don't like TCAR for this patient. Transfemoral?
Any transfemoral users in the room who would do it?
I mean, as first option, huh? As first option.
First option for you?
No.
Anybody else? First option? Piotr? Lots of people? First option? Transfemoral? Okay.
Endarterectomy?
Any endarterectomy people?
You mentioned that.
Like that. Okay.
Remaining,
What we did, transradial?
Yeah, there's some transradials.
That's what we tried the first, transradial. We don't have much experience, so we asked our neurologist, interventionalist, and cardiologist to join us and help with that. Impossible access. Impossible.
Peter?
Why was it impossible?
It was because of the angle of the left common. So the sheath in that configuration was not stable, and we couldn't reach the lesion.
Please go
many
back
times.
to the,
Sure.
to the images.
Sure. It's because of here was the problem.
Needs
Here.
to be proven.
Should
Needs
we
to be
ask
proven.
a cardiologist who is more experienced in doing this than us?
Okay. Actually, if I see a picture like this, my first idea is to go, we go from radial. That's because in an anatomy like this, with the mammary, internal mammary artery catheter, I think that we usually go in the external with the supportive wire, and then we try to go maybe with the 5 French destination,
Yeah, okay.
and to follow with a road saver or a small carotid.
I think it's really good to discuss this. Your experience, it's important to make the decision.
So what did you do?
TCAR. TCAR. We did it. We pushed the limits. This is the first picture. Second picture.
I guess we do not have the 5 centimeters.
We
and
don't.
before.
We don't have that.
So this is only a
And
TCAR
the-
for experienced hands.
no,
not sure.
but you know what?
You are very close to the bifurcation.
I'm showing this because we failed. You can see the huge dissection in the common because of the access. We have to convert. We started with transradial. We're not successful. Converted to TCAR. Not successful. Converted to CEA. Painful.
For the
Nightmare.
surgeon, for the physician or for the patient?
For everybody.
Yeah.
The patient was fine. We lose years of aging that day, for sure.
Yeah, yeah.
But I think the message is, for patients like this one, you need to have as many tools in your armamentarium as possible. We always have the patients that push the limits for us, and we need to try to make the right decision.
Fantastic case. Thank you.
you.
Thank you.
I think that the main message could be prepared to change the option.
Yeah.
You may start by transfemoral. You may also skip to the radial or brachial.
Yeah, make the decision, evaluate the access, make your decision, first option, second option, third option, and be ready for that.
Okay, but
Thank you very much.
you're a vascular
I
surgeon.
think we
have
have
to move
one more
on.
comment and then we have to go to the next one. I
Lady
think the
first,
only thing,
Amazon.
what
Lady
you have to
first,
say to
Amazon.
the audience, if you're unable to do the 3 techniques yourself, make sure you have a good team around you, because that is more important than you doing it.
So
Absolutely.
thank you.
Thank you.
One comment.
Thank you for
Okay.
the nice presentation. I was wondering, why not for transfemoral? Because of the bovine arch? Was that the reason?
Yeah, the bovine arch, the origin of the left common, the low bifurcation in terms of access was not easy too. The external was diseased, so we thought we wouldn't have enough support for that. So that was the reason.
Okay, great.
That's one of
Thank
the
you,
reasons.
Nacho. Thank you.
Thank you.
And we move on. To interventional cardiology, move on to Piotr, who's going to talk about lesion preparation before stenting, the key to success.
Thank you, Alison. Thank you, Eric. It's great to be here. It's great to see so many people on the morning of the first day only. So it would have been a transfemoral case for us, I have to say, the previous one. We would have tried transfemoral, and there's ways you can do to, with experience. Nacho mentioned things like extra stiff wire, for instance, in the external carotid. This gives us more room for the devices. But now we are to lesion preparation prior to stent. Key to success or not? Do we need it? So, because this is what Professor Holliday, Isabel, Nacho, because that's what they see, and those who assist vascular surgeons, for a long time the classic view is that endarterectomy can only cure because endarterectomy can remove this material. You agree with me? That's one of the ends of the spectrum. A lot of cholesterol, some thrombus here. The other end is calcium. And CAS is just a treatment, yes? To many vascular surgery colleagues, CAS is a treatment that, would not cure. There will be problems when you place a stent here. There may be plaque prolapse. With a calcific lesion, you may not be able to expand your stent. So for those who do CAS, let's see how often people predilate in the room. Nearly always. Anyone who nearly always predilates? Okay, so what we have, 20%? Frequently?
Piotr, maybe we may ask at certain rate of stenosis. For example, it's quite 70%. Personally, I do not predilate. If it's really pre-thrombosed, I always predilate. I think this is the gap. And I think if you want to be frank, you need to ask the question like that. What is the rate for predilatation, the rate of degrees of stenosis, percentage of stenosis for predilatation?
Okay, but I think I can, in fact, challenge you a bit, Eric, because I don't think it's the stenosis severity that matters.
Maybe.
What matters
Maybe.
is what's in the wall, at least to some extent. So if we have this, you want 70% lesion, fibrotic, for the discussion now? Who predilates?
No.
No? But, let's say regardless of the lesion type, yes, the approach would be lesion specific. Who frequently predilates? Okay, 50-50? No? Sometimes only? Okay. Rarely? Hardly ever? Almost never. Direct stenters? A few. So, Eric, that would place you where in this list here?
Sounds like they're in the middle.
Yeah. In the middle, yeah, about 50%. So who thinks they know when to predilate? You say the lesion severity, yes?
Yes.
Yes?
Yes.
Let's elaborate on that. So when would you predilate?
When it's more than 85 or near to 90% of stenosis, yes.
So a tight lesion.
Yeah, very tight lesions.
Paolo? Severe calcium. Professor Schneider.
Same. It's a combination of calcific lesions and also tight stenosis. Most of the lesions I'm treating are 80-90%. I'm not treating moderate lesions. I don't like the idea of bothering the lesion with these stents. This is why I dilate. And mostly when
I like it. Plaque preparation.
Severe stenosis and,
Tommaso, so severe stenosis?
and rigid plaque. I'd say not only calcific, but even very fibrotic, something I would think that the radial force of the stent wouldn't overcome in the first place.
That's getting really interesting. So how do you evaluate the plaque?
Ultrasound.
Ultrasound in your hands.
Yeah, obviously.
Okay. Anyone else?
On the just before the operation, not the ultrasound that brought the patient to the hospital.
Okay, so we look at the plaque prior to the intervention. Any other ideas? Angio? Angio may not be sufficient to make this decision. So we've discussed when to predilate. So who's had a problem in absence of predilation? Relatively few people predilate. Anyone who's not predilated and then they regret it, they should have predilated? 1, 2. Professor Schneider is very careful with his, choice of techniques. Happened to me too. I used to stand directly more. So who believes that nitinol stents grow with time? Nitinol has a memory, stents have a diameter. This is very common belief. So who believes, who knows, who's been taught that stents grow with time? You've seen it? Good. Where did you see it?
Yeah.
In the water, you say? Duplex. Yes. In the water. You place the stent in the water and then it goes. No? In the patient. On calcium.
And this has been pretty well shown by Samira's book.
In calcium.
That within that, this is
Okay.
different.
Okay.
If you don't treat the calcium, the stent's not.
Exactly.
But these self-expanding nitinol stents, they do continue to expand.
Where they can.
Where they can.
Where they can.
And which type of stent? The old one or the wall stent, for example?
Yeah, we don't use the wall stents.
It's the precise.
That may happen in the past, but with the micromesh stent, I think it doesn't already happen, no?
Yeah, I don't have experience with the micromesh. Sorry, I started to yell there. But mostly we use precise and exact. These are old stents. They've been around for a long time. The activity is relatively predictable.
I think as far as I know, there's no data supporting the growing of micronet stents in the future. I don't know those data. In my practice, I haven't seen micromesh stents grow or expand 1 month later or 1 year later after implantation.
But to me, the critical point is that the stent will grow when the stent can grow. So when the plaque is soft, the stent will grow. In fact, colleagues from Japan published in Journal of Sky recently a paper showing that the road saver stent may grow in a very soft plaque and cause plaque prolapse into the lumen. Because the stent will grow when the stent can grow. When the stent can't grow, the stent will not grow. We've all seen examples of bad casts when the lesion would not be prepared and the stent would show significant in-stent restenosis or malapposition. Residual stenosis. Who's bothered by residual stenosis? Anyone? Paolo, you don't like residual stenosis. I don't like. Why? Isabel, why don't you like residual stenosis?
Well, it depends if it's a symptomatic patient, especially with hemodynamic features, they will not be doing too well. And also, you get told off by your colleagues who don't believe in carotid artery stenting. They say, see, it doesn't work.
Okay, that's an argument. Any other problems with residual stenosis?
How much residual stenosis?
Yeah.
Say 40%, 50% residual stenosis?
30%?
40 or 30?
40, 50?
At least more than 40 or 50, no. 30, this is not a restenosis, it's just a calcium compression, that's all. And there is no lumen limitation.
But maybe we should not have this calcium compression there. Maybe you should have optimized the plaque. So residual stenosis is a risk factor for in-stent restenosis. Paolo?
Exactly.
Yeah? That's what you wanted to say.
Exactly the reason why. So this is the reason why I don't like it.
Okay.
But how much?
Stent malapposition. That's another issue that occurs with plaque that is not prepared. You heard calcium from Professor Schneider, things there. What is the problem with stent malapposition? Any problem or no problem? You remember the first slide, Professor Rantner's endarterectomy, removing all the stuff from the vessel, saying, well, you stenters, you'll never get there.
This is very interesting, but what does it mean malapposition? This is malapposition after angioplasty, stent angioplasty,
Yes.
into the internal or at the bifurcation seat
there's-
or into the common
This is
carotid?
the room between the stent and the wall of the artery and the plaque.
Yes, but
Because
where?
there's parts of the plaque that prevent your stent from fully expanding. You may have malapposed part of the lesion there, creating space for what?
Is it beyond the plaque?
Yes, yes, between the stent and the plaque. Malapposed stent. Who's worried? Paolo, do you like it in the coronaries, malapposed stent? Why don't you like it?
In coronaries, I don't like it because it's something which is strictly related to stent thrombosis.
Oh, thank you.
But
Thank you.
I don't know anything about the same thing in carotid.
Has anyone seen stent thrombosis in the carotid artery? Yes. What were the factors?
It was due to neoplasm, actually, somebody with an active
Neoplasm.
malignancy,
Okay.
so it was not
Okay.
related
So
to malposition.
procoagulable
Yeah.
state. I understand. Other reasons? I've seen this from other centers, patients, examples with stent malapposition. So stent malapposition is a risk factor also for stent
embolism.
thrombosis. So this is the case in a box from last year. You remember that case, and this is not what we'll be discussing today. This is extreme calcium. Of course, this requires, there's no question here, this requires lesion preparation. You remember we prepared with IVL, we crushed the calcium, converted a non-compliant lesion into a compliant lesion. You can see on your right, the same lesion now compliant. We could stent, we could optimize with post-dilations, we could check with IVUS, and this was an optimal result. But this is the patient today. In fact, I've not chosen any special patients. This is the 5th
Piotr,
of
can I
December.
ask you a question?
Yep.
What did you use? What kind of protection did you use with it?
Sorry, where?
What kind of protection did you use to do that, to pre-dilate?
Last
this type of
year's
lesion?
case.
Yeah.
Double protection,
Double
proximal protection and distal protection, because current IVL technology requires time to charge, and some patients may not tolerate proximal protection. So for us, if you use IVL, it's routine to use double protection, proximal protection plus a filter. But this is a symptomatic lesion here of what percentage? 50? 60? Yeah? So that's what we have. What would be the strategy here? Predilation needed, not needed? What do you think? Direct?
Should we ask the audience? Raise of
Yeah,
hands
yeah.
of direct stenting?
Okay,
Okay.
not so many, maybe 1/3.
Pre-dilation?
Interesting, Isabel. I didn't know you were a cardiologist, a bone cardiologist, Isabel, so why would you predilate in this case?
Maybe I have been influenced by cardiologists. That could be the reason.
So this is how we treated the lesion. You can see predilation. In fact, the predilation was initially with 5.0 by 15 millimeter stent. Then I moved to 5.5 by 15 non-compliant balloon. You can see the result after predilation. You can see the stent placed. Optimized stent with 6.0 non-compliant balloon, the final result. Now, Professor Rantner, good, bad? Sure.
Were you not concerned, irrespective of your protection devices, to predilate a 50%, if at all, from the angiography, 50% symptomatic, high vulnerable plaque? What is the issue of
The plaque was actually quite fibrotic, which I didn't
okay.
say. I didn't say on imaging. If this was a thrombus-containing plaque, we would have used proximal protection. We may have some problem now because of MoMA is not going to be available soon, totally. But this is what the result is. So this result, you can see here the other projection, is we believe full endovascular reconstruction that was enabled, I believe, with the past experience of not being to fully optimize the stent, if I did not prepare the plaque following the coronary strategy of plaque preparation and optimized stent post-dilation. So in 2025, I believe we can cure the patients with this technique. This is IVUS in this patient, just to show you that the effect, I hope, resembles the effect of endarterectomy of Professor Rantner, except that here you don't even see where the stent is, yes? If you don't know, this is full, and this is just one patient chosen from a week ago. These are the intra-procedural images for you. You can see where and how you position your stent. And this is stent stent post-dilation optimization and under, in this case, filter protection and the final result. Now you will ask me, Piotr, but why are you doing this all? Maybe this patient would have been fine.
Sorry, we just need to keep going because we're a bit over time.
Okay.
I mean, I think you're ahead there. You won.
So you want me to stop now, Alison? Or because I just want to show one last thing why we do this. So this is patient 3 months after stenting of right internal carotid artery. You can see full endovascular reconstruction, healed stent. Similar strategy was followed. Now this is part of Paradigm OCT study. We verify the result of stenting, the healed stent. You can see a beautifully healed stent. You can see micronet behind the stent. And I just want to tell you why we do it. We do it because we have evidence from the Paradigm study. This is the randomized trial data, where we looked in the first 500 patients, so optimized predilation, optimized postdilation, micronet covered stent. We had 0% stent thrombosis in 533 cases in those 500 patients, and 0.3% instant restenosis. So this is a new generation of carotid artery stenting. We believe that you need to prepare the lesion, you need to optimize your stent. You can see 85% predilations were 3.5 to 4.5 balloon. There was 10% of direct stenting in this study. Post-dilation, 60% post-dilations, 5.5 to 80 balloon, so full optimization of the vessel. Good CA-like result, and the vascular reconstruction that is also important in stroke. Those who treat stroke patients, tandem lesions, you need to optimize your stent, otherwise there's a risk of stent thrombosis. And with this, I want to thank you.
Thank you.
Thank you, Piotr.
Shall we ask the audience now? You asked at the beginning who would pre-dilate, if anybody has changed their mind.
To use also for CAS the vessel prep. This
So
is the
who
message.
would use vessel prep for CAS?
Tommaso, you want microphone?
That may make sense, yeah.
So, but let's give mic to Tommaso because he wants to come.
Yeah, Piotr, no, just a question, short answer. In highly calcified lesions with a proximal protection, would you predilate with, how do you call them? The balloon?
IVL or?
Yeah.
Yeah, that's our routine strategy. Otherwise, it's a CA case.
But you have to be very careful because some of these particles, although they say it's not possible, they do end up in the flow reversal.
Sorry?
With the lithotripsy, if you have proximal protection, those particles do end up sometimes in the filter, although people say it's not.
It's good. That's what proximal protection is for.
Okay.
I mean,
Okay.
that's
We
the
move on.
aim for
We move on.
professors.
We need to move on. Next speaker.
Thank you.
Peter, we're crossing the Atlantic from Krakow to San Francisco. Peter Schneider.
Thank you.
TCAR is safe.
Yes,
Recently
yes.
symptomatic
Well,
patients.
I think there's a decent chance that TCAR will be more widely available throughout the world. So this is something that we've had a lot in the U.S. over these recent years. And there's some early adopters here in the audience, such as Nacho Leal and Isabel Van Heersel. And I think it's coming back because now this is before it was a startup company that was providing this. Now it's part of Boston. The other thing is...
Sorry, they got put off by the legislation here, basically, at the beginning. Has the legislation in Europe got better?
Yeah, no, I don't know anything about Europe. I just know that it's in the hands of a concern that can make it more widely available.
I think the focus here is on that it can be safe. All these political issues, maybe we can discuss that during coffee.
Yeah. And then the other thing just worth mentioning, so I was just going to show you some of the latest data here about these super high-risk patients. So you've probably seen these studies, Roadster 123, VQI, SVS, and National Inpatient Sample. So these are all studies that have been done over recent years that now there are over 150,000 cases, which again is primarily in the US, but now it's available in China and Australia, and other countries will follow. So now when we think of these high-risk patients, the ones we worry about the most, the ones that we're concerned that a bad outcome has a higher risk, such as those with a contralateral occlusion or those with a recently symptomatic stenosis, you can see the latest VQI data here. So this involves 124,000 cases. These are propensity matched, and you can see stroke and death with TCAR in high-risk patients was 2.6, with CEA was 3.4%, and transfemoral 4.1%. And I think it's a little bit hard to stress, but even the discussion of vessel preparation changes when you have good neuroprotection. So vessel preparation for transfemoral is frequently, I put the smallest balloon to do the least disruption so that I can slide the stent in without any daughtering of the lesion. I open the stent and then I decide, do I post-dilate or not? This is, I think, pretty common practice for many of us, unless it's a lesion that's so heavily calcified that you either shouldn't be doing a stent or you're thinking about IVL. So, but with flow reversal, especially robust flow reversal that you can count on that leads to lower risk of even DW MRI lesions, this possibility to do, like I said, the most disruptive thing up front or to actually manage highly calcified lesions comes into play. And just to be fair, this TCAR concept, although it's been popularized by one group, there are now flow reversal efforts going on with multiple companies, Inspire MD, Abbott, and at least one other. So, being Contigo, or this is Medtronic. So, flow reversal is in our future, and I just want you to see what the possibilities are with this technology. So, this is now propensity weighted data that is accumulated in the VQI since the U.S. Regulators decided that transfemoral stent should have equal footing with CEA and with TCAR. And what you see is these are high-risk patients. You can see stroke and death with CEA 2.1%, TCAR 1.5%, transfemoral 2.4%. And when you compare TCAR with CEA, the adjusted odds ratio is in favor of TCAR. Again, these are high-risk patients. When you compare it with transfemoral, it's not just in favor, but it's significantly in favor, with transfemoral having a 1.57 times higher risk than with TCAR in high-risk patients. So we know contralateral carotid artery occlusion is a problem. We know this from the higher risk that we've experienced in CEA. And here are just a couple of studies that highlight that, one in symptomatic and asymptomatic patients, the other one in only symptomatic patients. And I myself, over these years, have been very concerned whenever I have a patient with a contralateral carotid occlusion, because if the blood pressure is too high, you worry about the ipsilateral hemisphere that you're treating. If it's too low, you worry about the contralateral hemisphere where the occlusion is. So here are patients with contralateral occlusions, TCAR versus transfemoral. And you can see again with asymptomatic and with symptomatic patients, the odds ratio in these propensity weighted patients was significantly in favor of TCAR versus transfemoral. And here is now contralateral occlusion, TCAR versus CEA. In the asymptomatic patients, the odds ratio 0.44 actually in favor of TCAR. In symptomatic patients, they were equal with an odds ratio of 0.97 and a non-significant p-value. And then contralateral carotid artery occlusion, if you look at all of the patients in all of the studies, the VQI, the national inpatient sample, and the Roadster 1, 2, and 3, approximately 10 to 12% in each of those studies had contralateral carotid artery occlusion. And here's just a study from VQI showing that in the patients with no, that is a patent contralateral carotid or no occlusion on the contralateral side, when you compare those with a contralateral carotid occlusion, the results were essentially the same, not significantly different, 1.5 versus 1.7%.
Peter, can I interrupt you there? Should we ask the audience, if you have a patient with an occlusion on one side, how it actually changes their management strategy? So, okay.
This does not change my management strategy.
Okay. Anybody else? Alexander?
If there's a unilateral occlusion, I would look at the factors. Should I do a classic carotid nephrectomy or a stenting? If I do classic one, I would use a shunt. And if I would stent, look if it's possible to do transfemoral. And if it's transradial, I would send it to my colleague who does that.
Yeah, and I think these are very appropriate. I think the point here is that the quality of the neuroprotection really shows here. And I think flow reversal, this is just my humble opinion, but I think even those like Piotr, who has a muscle memory from hundreds, if not thousands of transfemoral stents, when flow reversal becomes more available and reliable from a transfemoral position, I will be eager to see how people adopt it. As I think this is going to influence our future. This is now the way that stent is going to be sort of competitive with CEA, in my opinion. And this is what we're seeing in the US. So I talked about contralateral carotid occlusion. I'll go quickly now to recently symptomatic. In a way, I worry about these even more than the contralateral carotid occlusion, the patients who are recently symptomatic. And here just this is from clinical practice guidelines, the idea that you wait until the patient's neurologically stable, hopefully at least the 48 hours, but then you do the repair between 2 days and 14 days. And you can see from previous CEA data that 3 to 14 days is safer than less than 2 and almost as safe as the long run. So let's look at TCAR in that setting. What you see is that transfemoral in that early phase really has a terrible reputation. Now, somebody may be so good with transfemoral, having done so many, and be almost like a plaque whisperer. But the truth is that transfemoral in recently symptomatic releases lots of particulate. And the question is your catchment system, is your distal filter, even if you have, say, a proximal protection, you have this concern about your little balloon pops out of the ICA, and now you have forward flow in the internal. So these issues keep coming up over and over. What you see there with the early, that is the 3 to 14 days, with regards to stroke and death, 2.5 and 2.9% for TCAR. This is comparing now with CEA. So these are about 50,000 patients, again, propensity matched, looking at that 3 to 14 day time frame, 2.5 versus 2.9%, not significantly different. This is a nationwide inpatient sample, TCAR versus CEA, 329,000 patients. Looking at stroke and death, both in unadjusted and propensity models, you can see really no difference in these symptomatic patients between CEA and TCAR. But when you divide it down into the symptomatic and asymptomatic, you actually see a benefit toward TCAR in the recently symptomatic. This is a Roadster 2, symptomatic patients, 0.6% risk of stroke and death with enrollment by new operators and new sites. This is really something to think about. So every single carotid study we've done, whether CEA or stent or some combination, requires highly vetted operators. Think of the CREST 2 that was just recently published. The operators had to show dozens of cases and with good results, et cetera. In this case, the US regulator said, okay, fine. If you want to roll this out, you have to use new operators and you have to use new sites, new centers. And what you see is that we got excellent results either way. And then this, I think, is my last slide.
So can I be very provocative? So does it mean that TCAR is for those who are not good with wires and catheters and are able to stent, while transfemoral is for the highly skilled ones?
No, I would put it just a little bit different. So there's some truth in that. There are always going to be, I could just say when I was learning transfemoral and teaching a lot of people transfemoral, some people should not do it. Some people should not be doing transfemoral. And I'll just say there's a lot to learn. There's a pretty good learning curve. It is possible to cross or to surmount that learning curve. But I think when you're looking for a technology, to me, transfemoral is something that should only be in certain centers. I think people who focus on it, who do enough numbers, they get good results. This is a technology that I think can be much more widely dispersed. And I think the learning curves that we've seen are really different. Now, to be fair, all these people have to do 014. They have to understand carotid disease. They have to be able to...
But I think the key in TCAR is case selection. And what nobody says from the United States is that you have a very good person within those companies who's helping you to pre-select those cases. Is that not correct?
I think there's some truth in what you're saying, because, but think about it. Nacho started with, well, you would never do an EVAR without full preoperative, but it's not just the image, it's the analysis of all of that before you start. If anything, honestly, if we had understood what was high risk for transfemoral prior to the original CREST trial, transfemoral would have done much better, in my opinion.
But
in
Peter,
any event,
Peter, just your original group of patients with contralateral occlusion, haven't they already got good collaterals? I mean, is the discussion you're having actually necessary? Aren't they safe with transfemoral and TCAR?
well, I'm not here to say one thing is better than the other. I'm only here to say that every single one of these cases should be analyzed for the presentation, for the anatomy. I do think that flow reversal with transfemoral will come. And what we've seen here is that flow reversal just provides better protection, but it has to be robust. I don't think a bag on the floor is going to do it, personally. Having done every flavor of homemade myself, plus robust with a femoral vein sheath and with high-level flow. Nacho?
Just a quick reminder, contralateral occlusion was an inclusion criteria for roster trials. And roster 1, it was more than 30% of patients with contralateral occlusions. And in my personal experience, I have tried for many years to predict, for example, intolerance to flow reversal or things like that, studying intracranial hemodynamics, and I have miserably failed because there is
to predict.
No,
Yeah.
That's not.
Tommaso?
Very nice presentation, really. I appreciate 99% of what you said, but I think there's a misunderstanding.
The 1%.
Yeah,
okay.
On the 1%. The 1% is, and you said it between the lines, that flow reversal and TCAR are not the same thing. When you mentioned transfemoral, you always think of distal protection. Some of us do proximal protection with flow stop, and some of us even do flow reversal. And though we don't have the flow metric data on the intensity of the flow reversal, we've got the MRI scans we deliver the patients after, and we see we have a very reduced number of microembolization, so it works. So we don't actually measure the intensity of the backflow. Thank you.
I agree, by the way. It does significantly reduce DW MRI lesions. And not every patient can have proximal protection, just given the anatomy. Many can. But it's the same with all these. There are patients we don't want to do CEA, patients we don't want to do transfemoral, patients that we don't want to do TCAR based on the anatomy and the presentation. And I think this is where this multidisciplinary ability to have discussions across specialties and also to be robust in our pre-treatment analysis, which we weren't doing 10 years ago. I had to raise my hands when he said, how many have done transfemoral with no, basically no pre-op imaging. And we would go do an arch angiogram and say, oh yeah, that looks good. And do a transfemoral stent. It wasn't the right way to do it. Maybe for starters it was.
Okay, we need to conclude. And thank you, Peter, but you are always frustrating us because we do not have TCAR in Europe. And we always
okay,
have
Eric,
this
I will give you a good solution. So there's a workshop today after lunch where you can see the homemade TCAR of Nacho. You can see all the filters, where you can see all the flow reversal, whatever is available. And all the people who are talking here today are also at those sessions, so you can talk to them and ask them more questions about it.
And the next speaker, this is, yes, thank you, Peter. Next speaker, this is Laura La Capoccia. Decision making in carotid near occlusion. Please, Laura.
Okay, thank you. It's a big honor and pleasure to be here and speak about near-occlusion. So let's speak about this near-occlusion and the mysteries of it and the indication to treatment or not. Okay, we have some concern when we speak about near-occlusion, of course, because I don't know how many of you, when face a near-occlusion, fear the embolic potential of this kind of plaque, of the kind of stenosis, or otherwise they fear the hemodynamic impairment that the near-occlusion can cause. Or even someone is concerned about the increased potential risk of hemorrhagic conversion of the ischemic lesion when present in symptomatic patient. So I have to say that you know that we have not so many indications about guidelines on the near-occlusion. We just have, luckily we have, the indication of the European Society. And what we know that in asymptomatic patient there is no indication to invasive treatment when we do not have symptoms. And when we have only recurrent symptoms, we can consider to operate on this patient by endarterectomy or stenting. This is the indication we have. And this is what is suggested from the guidelines. When we can proceed with intervention, we can proceed only after a multidisciplinary team review that I think is crucial to every decision we have to do, as we have heard this morning. So let's go to the case. We had a patient that was admitted to a vascular laboratory, to the neurological one, for a carotid occlusion. He was diagnosed a carotid occlusion. So he went to another laboratory in our hospital. He was a male, 70 years old, with hypertension, ex-smoker. And when asked, he reported occasional dizziness, steadiness. But also when completely asked, he also reported a chest pain, and we will see why this chest pain. The neurologist was performing the duplex ultrasound, so made a neurological evaluation and found no neurological deterioration at all. But when performing the duplex ultrasound, they found that that was not an occlusion, but a near-occlusion. And the patient had a previous, the year before, a 60% stenosis from that side. So this was a significant progression. We performed an angio-CT that confirmed the near-occlusion, but also a cardiological workup. So we asked the cardiology, oops, sorry, how can I go back, okay? And the patient was submitted to coronary angiography, and 2 stents were implanted in urgency in this patient. So the patient started a dual antiplatelet therapy, and we asked the cardiology to check, of course, the supraortic trunk. Why not? We were there. Okay. So this is what we found. If you look carefully, we had a distal vessel lumen collapse in here, but first of all, the external carotid artery was, the angiography showed that this was, the majority of the contrast went in the external, not in internal one. So we had the doubt, is this carotid artery still his role in the blood flow supply to the brain or not? I don't know if we can consider this patient completely asymptomatic or not, but for sure, he is not simple to define if he had recurrent symptom or not. This is.
Let's stop. Is it
yeah.
Dominant hemisphere or not for this patient?
What?
Dominant or non-dominant hemisphere?
Not dominant. This was a right one.
Okay. And he's left-handed. Right.
Yeah, left-handed. Right-handed. So left hemisphere dominant.
Did you consider the cerebral situation?
Sure.
Silent ischemic lesion?
Yes, I'm
like
going
that?
to show you.
Okay.
Yeah, of course. So, at first evaluation, what to do? Consider or not to operate on this patient. We plan an endarterectomy, a carotid stenting or not, just best medical therapy. Why not? Okay.
Before I decide on lesion strategy, I would like to know whether the patient has indication for carotid vascularization. So I would request perfusion imaging of the brain.
Perfusion one or just the angiography of the cerebral circulation?
No, perfusion imaging, CT perfusion imaging of the brain.
Okay.
Because even that this is a non-dominant hemisphere, he's 70 years old, his coronaries are fixed now, he may have 20 years of life ahead of him. Also, the status of the other carotid would be important to me in the decision-making process, but I would like to know, the functional impact of this lesion.
Yeah, but I have a question for you. The patient was now asymptomatic. So what do you expect from the perfusion?
Well, clinical symptoms, I think, come late on the ladder. The first is what I expect from perfusion. I expect either equal perfusion of both hemispheres, or I expect to see this hemisphere is hypoperfused despite the supply from the other side that I think is present
Even
in this
if
patient.
the patient was asymptomatic, neurological asymptomatic
All
now.
right, this is the non-dominant hemisphere. You are the expert on,
No,
fine
I'm not the expert.
neuro tests and imaging, things we don't know. I think when they come with grave symptoms, it's all too late. We should pick them up before they get those serious symptoms.
Yes,
yeah?
but sometimes perfusion can be misleading.
Before he becomes hemiplegic on the side, on the non-dominant side, I would like to know if maybe he needs treatment.
And would you proceed in case of impairment of the perfusion on that hemisphere?
This is a proximal neuroprotection case, in the hands definitely of Tommaso, Professor Schneider, your hands, Isabel, myself, Eric.
Okay, so let's go to see what happened. Any other question? No? Okay. So we had some issues to consider. I'm going to discuss them with you. First of all, the hemodynamic impairment, the distal lumen collapse or not. Was this really an asymptomatic patient or not? And of course, the importance of the intracerebral flow. Let's go to see the hemodynamic impairment. We have to consider the patient has just 2 coronary stents implanted. So it could happen that the patient could have an hemodynamic instability that could affect that hemisphere. Why not? The distal lumen collapse, you can see that we have discussed the guidelines. They say that in case of distal lumen collapse, the first recommendation, but please note that this a class 3 level B recommendation, are not recommended revascularization in those cases. But thanks to who wrote those guidelines, we still have questions. Of course, I'm thanking her. We still have questions, so we have room for discussion, we have room to improve and to give different indication. The real question is carotid artery near occlusion as benign as previously thought? I don't think so. I don't think it's really benign. So we checked for the blood flow supply to the brain up to this level, and also if the patient was asymptomatic or not. We should say that it was asymptomatic, and we could discuss, if you want, what is the new indication nowadays for asymptomatic patients, but it's not the topic of my talk, so we can discuss after this, if you want, the new trial, because we have no time. Yes.
These will be discussed tomorrow, so no need to focus on those.
Yeah.
Okay. And let's go to check the intracerebral flow of this patient. So this is what we found. We have seen this. We checked the posterior circulation too. And surprisingly, this was the contralateral one. On the left side, the left carotid supply all the circulation for the entire anterior circulation of the brain. So a communicating anterior artery, and the supply was the anterior cerebral artery, middle cerebral artery of the contralateral one.
And he's already on doublet antiplatelets.
Yeah. What would you do in this patient? With a good collateralization too, as you can see.
I'm going to ask somebody from the audience.
Yeah.
Thank you. In the image that you had on the ipsilateral side, there might be a tandem lesion as well. So actually, if you do revascularization of the right side, you don't know what will happen to the flow. I agree, we maybe in Helsinki would have a perfusion imaging, and then we would have a TCD provoking from the neurologists. I think you can choose either, and I think you can end up in a catastrophe if you operate and if you don't.
May I ask who is considering to operate in this patient? What?
Any intervention. Could be anything you do.
Any
Piotr,
intervention,
any intervention
or operation in the context of,
Any carotid intervention.
Any
Any carotid intervention?
I think the coronaries are sorted out, and that's actually really important, and congratulations in this patient. The problem is if somebody starts to mess with the carotids before sorting out the coronary circulation. So I'm not bothered about any kind of instability now. I'm still not sure about the indication. What relieves me a bit is the fact that the left carotid has no lesion, so he may be well off for the next 20 years just living on this left carotid. My concern would be now, do we have an indication? You know, it's always better to have two carotids open than one carotid.
Exactly.
So if I get a perfusion scan that shows that there's hypoperfusion of the right hemisphere, I go for proximal protected carotid artery stenting with flow reversal.
So does he
May I ask you what kind of stent?
Does he have any brain imaging, or does he have any emboli detectable?
Not emboli. I don't have the images, I'm sorry.
We did not. We were still waiting for cerebral imaging. No silent ischemic lesions, no infarction.
Not
Due
really.
to this rapid progress, you would expect something, either embolization or hemodynamics. So that was completely asymptomatic.
There was no recently one.
Maybe there's nothing there because there is no real antegrade flow to the brain from the right side.
Yeah,
I have a
there
neurologist
is a completely supply from the other side. So we found nothing really urgent.
So thank you very much. I do doubt if perfusion CT will give the answer, actually. I would go for or PET scan imaging with Diamox or with TCD imaging to have a vasomotor reserve capacity. The second thing is, regarding on your DSA, actually you should look at the venous face, whether there's a symmetrical filling. And once that's okay, then there's actually, I don't think, any reason to recanalize.
Yes, we checked the venous face also,
yeah, so
and it was okay.
We sometimes actually occlude with giant aneurysms. We occlude the ICA, and people can become 100 years with the not occluded ICA.
So you're going to have to tell us the answer, Laura.
Yes. Isabel, shall we vote to conclude the case?
Yeah, we ask the audience. Okay.
Who wants to treat technically to intervene on these near-occlusion carotids? Raise hand. Okay. Oh, yeah? Okay. Very few people. You use the G card? Okay.
I need to know a little more. But I don't understand this exercise of concern. This needs to be fixed. I don't see, there's no data that's telling me that this should not be fixed. How do you know when that artery goes down, he's not going to have a massive
Nobody
stroke?
has got the answer.
Yeah.
I think that nobody has.
Right. So do you let nature take its course, or do you do what we're trained to do? Fix.
Thank you. Perfect.
You need to do your own cooking.
Okay, that's exactly what we did. So we delayed the lesion with 2 different balloons. And then we choose a newly concept of stent, the Caresto Hill stent. This is a new concept of stent. This is a kind of flow modulator. And this is very flexible into the carotid. And there's a technology, a so-called healing system, time, yes, for the purpose of time. This is antithrombogenic, and it has a good radial force, even if it's flexible like a flow modulator.
Brilliant, thank you.
Okay.
We'll have to stop.
Would like to announce the next speaker?
Thank you. That's because you can't pronounce it. Paolo.
Oh, Paolo Sbaraglia. From Italy.
Yes, absolutely.
Prego.
Hello.
Back to cardiology, back to Italy.
Okay.
Yeah.
So, first of all, thank you for the invitation. I really appreciate it. And what we are talking about today is the treatment with carotid stenting in case of a CA restenosis. First of all, just to show the phenomenon, what we are really talking about. So CA has a restenosis which is, in literature, appears to be for a restenosis superior to 50%, between 5 and 22% at 5 years, and superior to 70% in cases of 2 to 10% after 5 years. And we know that we can find restenosis at the site of the lesion, of the incision site, and there's some, this big review shows the difference between all the different surgical techniques that can be used, and also we can have some lesion at the level of the clamping, both at the distal clamp and also in the proximal clamp. And there's some evidence that the procedural time and the clamping time during the surgical procedure can be a risk factor for an early carotid restenosis at that site. So if we need to treat these kind of lesions, we have to consider, I think, these main three factors: that we have a different kind of plaque, which is what we find from the standard plaques that we use when we have patients which are not being operated. So it's a more fibrotic plaque with a very much more fibrotic composition, so it's a more stable plaque, even if in some cases obviously this patient can be symptomatic. So the combination of these, the fibrotic component and the symptoms, can be a very important, the two factors leading to the stent choice and EPD choice. And
Paolo,
sure.
Back to what Piotr mentioned. You think also in restenotic lesion, we also need to use the vessel prep technique to predilate before stenting? Do you see it is very useful also in very fibrotic lesions such as the restenotic lesion?
I think that it can be very important. Sometimes we have to do it because we have a much tighter lesion, and so we need to, we don't want to make a daughter effect, as Peter was saying, with the stent. And so in those cases, you can do even an aggressive predilation using cutting balloon, just to have a good predilation of the plaque. And also the site of the restenosis is another determinant of our choice in the EPD that we are going to use. Obviously, if you have a lesion like the one in the common carotid, you're not using MoMA. We're not going to use it anymore anyway. But anyway, it's very important that in that case, you only have the possibility to use a distal filter.
So does the time of restenosis concern you? If it's a long time, do you think they may have more atheroma, for example?
Yeah. That's exactly the other point. In an early restenosis, you have a more fibrotic plaque. A very late restenosis, between more than 4 to 5 years, so you have something which is more similar to a standard atherosclerotic lesion, and so in that case, it's not that different. The main difference is when you have a very fibrotic and very early restenosis, which it makes a difference.
Yes, Piotr?
I think what Professor Halliday has just touched upon is really, really important, and it's not fully recognized. If you look at the mechanism of instant restenosis with first generation stents, within the next year or two, because we've done a series, it's going to be published hopefully, intravascular virtual histology analysis. So it's either fibrotic tissue, but in many, many lesions, especially those later cases, it's just progression of atherosclerosis. And there's no difference between so-called restenotic plaque or an atherosclerotic de novo plaque. I would assume this would be less with CA because you totally remove the material, but maybe not completely in all cases. Really, really important point. Thank you.
Please, go on.
Okay, so, this is a case, a recent case that we have done, and this is a patient with hypertension, dyslipidemia. She has a previous nephrectomy and a previous non-Hodgkin lymphoma, which was treated not with radiotherapy but with chemotherapy. And she has a previous ischemic stroke in 2021, and she has an evidence of a severe stenosis of the right internal carotid. She was treated with carotid endarterectomy. In the early 24, she made a CT scan in the follow-up and showed a restenosis which was seems to be more than 50%, and she made also a carotid ultrasound showing a severe acceleration with PSV superior to 2.3 meter per second. So she was admitted at our institution for a carotid angiography. This is the aspect of the angiography. This is a lateral, this is an oblique, left oblique view, and this is a lateral view in the middle here.
This is more than 50%.
This is much more than 50%.
Paulo, may I interrupt you? I may have missed it. It's here. You had a duplex scan and then you had the CTA before you do the angiogram, or you just go directly for your angiogram?
CT and duplex ultrasound.
And to echo to what Isabel mentioned, do you have also investigation before this 3 year after procedures, because that's happened 3 years after? Do you have duplex or CT scan before, or when does it happen, this restenosis?
This the final part of a long path with many CT scans and duplex ultrasound, which were not very clear about the good results from the very beginning. So this, probably there was something growing from immediately from the very beginning of the post-op phase. And actually what we found here is very clear in this lateral view, and that we have this very stenotic lesion and also 2 lumens. It seems to be a dissection or something like that. And there's... Sure.
I see Professor Ratner and Laura are discussing, and I think what they are discussing is, was there a post-op verification of the quality of the CA, yes? Because I suppose that the result was not ideal to start with. Do you want to comment, Barbara?
Yes, yeah. We were just wondering what kind of reconstruction it was. It was done an eversion with, because it doesn't look like a patch, or how was the common treated? So we were just discussing how this initial treatment was performed.
Actually, unfortunately, I don't have these data. Because it wasn't performed in our hospital. So she went at our center only after these late findings. So I don't have any data about this.
And the other thing I think Barbara was alluding to, that if you do carotid endarterectomy, we should ideally assess what we are doing. So have some final imaging, ultrasound, angiogram, whatever you're doing.
Yeah.
Who is doing, after carotid endarterectomy, an angiogram or anything?
Because I'm not capable of endarterectomy, unfortunately, but I do an angiogram in every case after carotid stenting, and that's the difference between the 2 techniques. Carotid artery stenting is automatically verified in its quality by post-procedural angiogram. And you recommend in the guidelines, yes?
It is in the guidelines, indeed.
It is. Yeah. Yes.
So there is the recommendation. It's irrespective of angiography or ultrasound, but there is the recommendation to perform quality control also after endarterectomy.
During the procedure.
On
during
table.
The procedure. Angio during the procedure.
Yes, on table.
Table, yeah.
On table. Okay.
However, we don't know the answer because it hasn't been done in the institution. So.
Okay. So, and this is the antegrade flow intracranial level. So with the poor circulation and no evidence of the anterior cerebral artery, which is probably compensated from the left side. So what we did in this case, so the main issue here was to do the wiring of these lesions. because obviously, I don't know if you have an idea of which of these two lumens could be the right one. I don't know if you want to make a vote or whatever. In my view, I make a disclosure. Just to, my first idea is that this was on the right, was the right lumen to go.
Paolo, my dear, but you're already going through the wire. Tommaso, would you stick a wire into this lesion without protection?
But you are using flow reversal.
Yeah, I wouldn't fiddle with that lesion with 2 wires. I mean, without protection before, obviously. Afterwards, it's interesting how you solve the lumen problem.
So Paolo would like to have a monoballoon to start with.
Okay. No, that would be much better. You're right. The idea is, so we started going in this lumen, which seems to be more promising, I would say, in this part. And the wire could go inside, but it couldn't advance. So we had to stop. And so we tried with, to wire the other lumen. And as you can see from this picture here, it went very easily in the second lumen that you have.
It's really weird, and you should have changed the angulation, the rotation.
Yes, this is exactly what I did. Because I tried on the first lumen, then it went very easily in the second lumen, so I changed the view, which is here. And
we need to mute Piotr.
In case you mess up a lot, did you have a backup of Laura and the operational theater next? Okay, thank you.
So what you can you see here is that these the second wire, which went very, very easily, was in the right lumen after the stenosis, and the other one was getting stuck in the wall. So obviously I didn't want to go pushing there, and we decided to, and we checked again in different views, and we decided to go with the microcatheter taken from the coronary field. So we took the fine cross microcatheter is going up here, and we are doing this picture with injecting inside the lumen just to assess and to double check that we were in the right place.
Just quick question, because maybe I missed it. Are you using any kind of neuroprotection for that wiring?
No.
As a friendly reminder, you can do TCAR in restenosis after CEA, and you could be protected before you start with the wiring of that kind of complex
Or
lesions.
at least to use the flow reversal.
I'll just use something.
But that's already, that's...
Any other technique to verify your lumen? You've done distal injection like stroke. If you want to make sure you're in the right. Any other ideas from colleagues? What else could be done to prove you are in the right lumen? Regardless of technique, proximal TCAR, I think it's important to see you're in the true lumen.
This is a comment or a demand?
No, it's a question. You can also do intravascular ultrasound, yes, to know where you are.
This was a possible alternative strategy, obviously using intravascular imaging, but obviously we had a bulky device and we were without any distal protection device. So it wasn't the good idea in my mind. So what we did is to put a filter with crossing. We had already the fine cross there. We put the wire and we went with a filter, and then we make a predilation with a 2.5 20 by 20 millimeters balloon because we had some friction crossing the lesion, and then we could go with a stent. We advanced a very long stent, which was a 9 by 40, but because the picture showed us that we had a very long dissection going very, very up in the internal. So we decided to stay very high, and then we make a post-dilation with this 5.5 balloon at all the length of the stent. And this was the final result, which was a good result, and we had a very nice catch-up also in the flow of the a good increase in the intracranial flow, and also a catch-up in the anterior cerebral artery. So just to conclude, so in this case, it shows that in case of these restenotic lesions after CEA, also wiring can be a challenging part of the procedure. In this case, I think that dual layer stent probably are less needed, mainly because of the early restenosis, which more fibrotic plaque, probably we don't need so much the use of a dual layer, and we also have the risk, the risk of restenosis, mainly for road saver. And the carotid stents with a higher radial force, like carotid or exact, are probably the best to choose in this case.
Great, thank you, Paolo.
Okay.
And we move on because...
Sure, perfect. Thank you very much.
Barbara,
Thank you.
Barbara needs help. She's coming from Munich and she needs help with symptomatic dissection.
Yeah, from one dissection to the other. Thanks, everybody. Thanks for inviting me again, Eric. It's really a pleasure to be here. And we're supposed to discuss the case of symptomatic carotid dissection. I want to start right away with my case. It was a 62-year-old, quite healthy female patient showing up in an external neurological department with amaurosis fugax on the right eye. And she was admitted to our department, and we did primarily the ultrasound scan and saw these images. Here in the wall, this missing perfusion. Here again, common carotid. What do you think this could be? Who opts? So the presentation is called dissection, so it's probably not that exciting anymore, but could it also be a thrombus or a soft plaque? Could... Yeah.
So does the ophthalmologist see anything?
Pardon?
Does the ophthalmologist, the eye doctor, see any?
No, nothing. So, well, we went for a CT angiography. Can we start? And I want to draw your attention to variability of lesions in the carotid circulation on the right side. So we try to focus on this, the internal to be pretty well coming from above. And then here we enter the bifurcation, and we have here this deficit. Then the common carotid, that has also, that's the area what we pictured in the ultrasound that is soon to come. So you can see here this perfusion deficit and the common carotid still with some calcium. And then going further down, we will see two other lesions, this one right here. And also at the origin of the common carotid in the innominates and also in the aortic arch. So slow motion CT scan, sorry. It was supposed to be a little bit faster. But now we are going down. You can see the lesion here, and also a dissection of the innominate artery here, going to the aortic arch. So it's probably not just a carotid dissection case, it's probably a little bit advanced, but that's the reason why we are here. So the patient showed up with no pre-medication, not at all. As I said, she was fairly healthy. What would you opt for in this situation? So one episode of amaurosis, or probably two, without best medical therapy so far. Who would opt for open or endo immediately after seeing the patient first time?
Or hybrid also, to mix open and endo.
Yeah, yeah. But at this point, who would treat her right away?
Do you need any other imaging of any sort? Do you need a cardiology opinion?
We would probably, she had a cardiological examination, it was fine. There was nothing. Probably we take Laura because you were so active already.
Laura.
So thank you, ladies first.
Ladies first.
Which was the cause of all those dissection? You had any information about this?
No.
No.
Oh, maybe nothing. This is one dissection plus
probably
two thrombotic lesions.
This is probably what was what. So We might probably
nothing
understand.
iatrogenic, nothing, no manipulation of the neck.
Nothing so far. 62 years old, pretty
62.
healthy. Piotr.
My first question would be, does this patient require any intervention at this stage? Yes, because you can mess up a lot. If this patient was presenting as acute carotid dissection-related stroke, then yes, she does require treatment, but she had one episode of TIA. She's fine otherwise.
Not even, yeah.
Medical therapy has not been tried yet. We can discuss anticoagulation or antiplatelet, and the patient would require a close follow-up, but I would not be very keen to intervene in this patient with any technique at this point.
And do you know exactly where the point of dissection was?
No. And we did not know where the symptoms come from. This is like probably we see in these tandem lesions in the bifurcation and the innominate, for example. It's always difficult to differentiate where the symptoms came from. So just a quick introduction to carotid dissection. The evidence is very low, just to give you this information right in the beginning. You always need to think about dissections in young patients showing up with neurological symptoms. And as you might know, neurological symptoms are frequently not as clear as in a typical atherosclerotic stroke. Can be headache, neck pain, or facial pain preceding focal neurological deficits. Some show up with the Horner syndrome. And due to this, diagnostics is frequently delayed. The best imaging would have probably been after we did the scanning with the ultrasound to perform a high-resolution MR and MRI, because this allows a better differentiation for intramural hematoma and intraluminal thrombus. We did a CT angiography, so we did not additionally perform the MRI. And what you need to be aware, and this is probably not for vascular surgeons, but more for stroke physicians, if the patient shows up in the early window of neurological stroke onset, then you need to decide if you want to perform intravenous thrombolysis, and then you additionally need to rule out large vessel occlusion in the anterior circulation in the context of extracranial carotid artery dissection. As I said, the evidence is fairly low. The ESO guideline on this extra to intracranial artery dissection chapter is also from 2021. I think it might be updated fairly soon. And this is what I just said, mentioned also there. If you see a patient with an extracranial carotid dissection in this classical time frame of 4.5 hours of symptom onset, then it's recommended with low evidence level to put him under thrombolysis and see if that brings some release, if standard inclusion and exclusion criteria are met. We talked about anticoagulation and anti-aggregation in this context. This is, however, also not that clear. If you want to opt for anticoagulation, then you could more or less do that. If you prefer to take anticoagulation, then that seems to be also fine. As I said, the guideline is from 2021, probably more evidence to come, but there is no clear recommendation so far. If you think about oral anticoagulation, it could be done by DOAC. It's not only vitamin K antagonists, or you could also opt for putting the patient under dual antiplatelets. So there is a big variability of recommendations. It's again in the discretion of the treating team probably. And we did best medical therapy, Piotr, started with aspirin and clopidogrel and put her on high-dose statins. However, she was symptomatic again 2 weeks after this intensive treatment. And this time it was not an amarosis, this time it was a hemispheric transitory ischemic attack.
Okay.
What to do?
This is
more imaging?
Yeah. More imaging?
No. Not sure.
Not more imaging? MRI? What would you have done, Alison? Then dynamic MRI. She obviously has some problem.
I think now she needs an angiogram, transfemoral angiogram, being prepared for going from up and from down in setting cell.
A therapeutic angiogram.
An angiogram with an idea of proceeding
in treating position.
Yeah, therapeutic angiogram.
More ideas?
Is she clopidogrel
Who
resistant?
goes for the surgery?
Is she clopidogrel resistant or not?
No.
Tommaso?
She was responder.
Angiogram, I would consider the dissection on the nominate trunk to do a selective angiogram. That would be a risk, adjunct risk.
And you need to make a new imaging?
I had a CT scan. I think I've got everything I need to decide what to do.
Yeah, it's a failure of BMT, so something must have happened, and we would definitely do re-scanning, re-imaging, whether there's more thrombus or something like that, and definitely not a DSA, because then you can, as you said, do a longer dissection. But it's a failure of conservative treatment.
She was a
you
responder
need to do
for both.
something, and then an MRA of the head so that you see if there's an emboli.
Mm-hmm.
I don't remember the anatomy if the brachial access could be possible in that case.
It could be. It could be. The brachial access was...
So what did you do?
So let's see what the recommendation might be first. So again, as I mentioned, the evidence is fairly low. There is no clear recommendation for endovascular treatment over open surgery in this context. And overall, the neurological recurrence rate is extremely low from extracranial carotid dissection. And so there is a general suggestion against routine treatment in these patients, irrespective of sufficient best medical therapy. And Pekka she was responding, everything should have worked fine in this situation. So we discussed in our team, and we decided and you did not mention it now again, Eric, so we opted for a hybrid procedure, because I was not glad with the situation in the internal carotid and the common carotid. So we opted for an open repair of this bifurcation pathology, and you can see here the embologenic material in the carotid, in the common carotid, and it was the same in the bifurcation. So we treated this with endarterectomy and patch, and retrogradely treated the common carotid artery dissection with the Seagard stent.
Wow.
So in summary, that was my case. We always need to keep in mind, especially in young patients, that it might be from an extracranial carotid dissection. MRI and MR imaging might be the diagnostic performance of choice, because it's not that easy to see it in the ultrasound and also CT angiography. You should consider intravenous thrombolysis if you are in this early window of neurological symptom onset. Endovascular treatment could be considered. The antithrombotic therapy is quite open, as I tried to show you. And then it's probably, again, a clear team approach to either choose endo or open or hybrid for those patients. Thank you.
Thank you so much, Barbara. We need to move on the next speaker. Thank you, Barbara. The next speaker, this is Prakash Krishnan, so-called PK, from Mount Sinai, and the carotid dissection that may happen and that needs to be treated.
Well,
PK, please.
Now after this wonderful session, I'm wondering why I'm last presenting complication, but thank you so much, Eric. No, but with all jokes aside, I really appreciate being here to speak to all of you. So this is a case that was very complex, and I think there's a lot of learning points that we can all discuss. So a 74-year-old female with hypertension, non-insulin-dependent diabetes, hyperlipidemia, ex-smoker who had multiple PCIs at our lab, who presented with recurrent TIA symptoms and a monocular vision loss in her left eye. So she had seen urology. She was optimized initially with medical therapy, was sent for an ultrasound and a CT, and you can see the medical therapy was there and the pertinent labs. She had a CT scan which confirmed the findings of the ultrasound. The ultrasound showed a left internal carotid artery stenosis of 80 to 99%. You can see the velocities there. And the CT showed a type 2 to 3 aortic arch. And therefore, at that time, we make a team decision at Sinai. We've been doing carotid stents with our vascular surgeons since I got there in 2000. So we've always been a combined team where we do all the procedures together. So with our vascular surgery colleagues and urology colleagues, we decided to take her for angiogram because she had failed therapy and had ischemic symptoms. So the choice for left radial access was made because of the complexity of the arch. So we did it just, again, we're going up to the left carotid, which was a bovine arch. And you can see here that we were able to engage the bovine arch with a radial catheter by placing the stiff wire in the external carotid artery. We tracked the terumo radial sheath across the common carotid innominate bifurcation up to what we thought was a good level. And then we went ahead and obviously this is the picture of the catheter. Then we went ahead and did a diagnostic angiogram, and you can already see, for those of you who can see, there's a little bit of an issue going on at the beginning of the sheath. However, we noticed this and we said, okay, let's just move on at this stage since we already have started the procedure. So the patient remained asymptomatic at this time, so we went ahead and did a diagnostic shot. You can see this confirmed the CT angio findings of contralateral filling of the brain from the contralateral carotid, and you can see the competitive flow very, very clearly. So since we had the pre-op imaging, we went ahead, and this is obviously the lateral shot and the Towns view as well that you just saw. So then we went ahead and placed our filter, and we did our pre-dilatation followed by stent placement. And I want you all to notice at the level of the sheath what's starting to rear its ugly head even more and more. So again, stent placement was done, and we felt we could probably tackle that on the way out. And we went ahead, placed the stent, good flow, still asymptomatic at this stage. So the idea now we thought was, okay, we placed the stent, let's place an 035 wire across. Again, we work together as a surgical and interventional team. And then we'll go ahead and retrograde and then place the stent from below through the sheath. So, as you can see there.
So are you happy with the stenting? Because we've already seen data today from Piotr and other that it seems like there's still a lot of residual stenosis, like we would call it. What type of stent did you use?
We used what's called the Abbott stent.
Which one? The Aculink or the Exacted?
I believe it was the Exact stent.
The Exact.
PK, do you always use this skin scale to measure on the?
Yes, we always do.
First time I see that.
Yeah, we always do. That's why we've been doing it for 20 years.
I never use it.
So yeah, so at this stage, I don't recall whether we post-dilated. I didn't look at that, and probably we did. And so at this stage, we put the 014 wire distal and then track the another stent into the common carotid to go ahead and stent the common carotid. And then at this stage, so you can see we're retracting the sheath, and we're using I believe a 10 millimeter carotid dedicated non-tapered stent. And at this stage, we went ahead and deployed that. And you can see there's flow, but now we still have to stent the ostium. So as we were withdrawing our sheath back, we unfortunately lost the sheath distal, and now we lost access to the carotid, and you can see where the dissection is. So we decided to take a picture just to help in the lawsuit to show that there was no flow in the carotid at this stage. And so at this stage, the patient started to be asymptomatic, so we got anesthesia on board.
This is usually the moment where you are alone in the operating room.
Well, it wasn't fun. It wasn't fun. So this is a sort of a nightmare scenario for us. So at this stage, we felt that we couldn't track anything through this. So while we were trying to track an 035 catheter through the sheath over the 014 wire, we lost complete access. So at this stage, when we lost complete access, we went ahead and got distal, that was the demonstration we were trying to track, and everything fell out. We went from the distal, got a VTEC catheter, and said, let's try to wire the carotid. So with the VTEC catheter, we use an 018 wire with an 018 trailblazer, and we're able to get back across the carotid intraluminally. And again, without introducing an IVUS, which we talked about, we said, let's just check with a check angiogram. So check angiogram shows we're luminal. And then we said, okay, at this stage, let's go ahead and stent. So now we have a catheter from below and a sheath from below, and then we went ahead and decided to put a transfemoral stent. As we were doing a transfemoral stent, we said, we need to check the ostium. Let's inject from the radial sheath. We injected from the radial sheath, and we retrograde dissected the innominate into the left internal carotid. So now we had to step out, change diapers, change pants, change all those things. Wasn't a lot of fun. And at this stage, you can see that the injection of the retrograde probably picked up plaque at the level of the ostium of the left common carotid and dissected right up. So now, obviously, we're in a lot of soup. So patients started, as you can see, moving around, very, very symptomatic. We were almost thinking about intubating at this stage, but we kept plugging on, saying, okay, we really have no choice but to move on. We called our neurointerventional team, which was on site, and again, we do carotid stents early in the morning, so everybody's available. They all were there at that time, and we're giving their input on what to do. So we said, let's go ahead and fix this. We fixed the left common carotid. We established flow, and now we had to tackle the right common carotid. So at this stage, we went ahead, retrograde wired the right common carotid with great difficulty. And this is where we had great discussion, and I think this is where the controversy is going to be, is what to do. So here, this is just flow, showing you the flow on the left now. And then after a great deal of difficulty, we wired the left common carotid. And then we decided to place a single stent at the level of the bifurcation. So you can see there's the wire. We found that what we thought was a distal plane with IVUS. So we found where the tear was sort of communicating, and we were able to confirm we're in the true lumen, and then we went ahead and put a stent there. And after the stent, we still had no flow because of the common carotid. And IVUS demonstrated that the tear was intraluminal at the level of the ostium of the common, and when we were in the lumen between the tear and the dissection. So we felt we should fix the innominate. So at this stage, we went ahead and put a stent in the innominate right there. Oh, actually, is it the same stent? Yeah, it's probably the same stent. No, in the ostium of the common carotid, right there. And you can see the stent going right there into the innominate. And then with that, long case here, let me keep going forward. We were able to establish flow with the innominate stent, the dissected segment with a true and false lumen in the ostium of the common carotid, and then a distal stent tacking up the distal dissection plane with flow in the right internal carotid and flow in the left internal carotid with 3 stents. So again, Eric wanted a complication. We got a complication. So at this stage, after everything was done, the patient recovered. We did this, obviously, she was seen by neurology, MRI was done. She was in the hospital. This is a year later. Again, there was no issues. Medical therapy-wise, she was placed on Plavix and aspirin and for life. And then the stents have been patent now. Even last week we saw her. She's been doing fine.
Wow.
Thank you. Who is not too scared to comment? Isabel.
I'm happy to comment. I think
Please.
you're just proving what Nacho has done, the first speaker of this session, is access is key. Anybody can do carotid artery stenting, but please look at your cases beforehand and discuss it multidisciplinary.
Well, we did have, I pushed back. I think we had a good multidisciplinary discussion.
Because you could have, if you would have done a T-car, you would never have had this problem.
Well, again, we did it with the surgeon. We have a discussion, and I think we've been doing carotid stents for 20 years with great success.
Yeah, but you know.
I agree. Access. I think the issue happened here was there was plaque at the level of the innominate, and when we made the turn into the left common carotid, we picked up plaque, and that just tracked all the way forward.
I mean, thank you so much for sharing this case. It's an excellent resolution of the problem. This is actually my fear when I go transradial when I can't go transfemoral. I think this could have been a transfemoral case.
Yes.
And forget the bovine. I think it was
exactly.
feasible, as you then proved, to reach from the bottom. But thanks very much for showing this case, because that's exactly the concern I have when I go transradial. Because the forces and make the curve, I use the rumodestination sheath. One other issue is to use a SIM catheter. This is 7 French in that case. But thank you so much for sharing this case. And congratulations on the resolution.
We're very lucky.
So do you have any advice for people who would like to start doing transradial? What should they look at? Based on this case,
sure.
What would you never do anymore?
I think in today's day and age, I think with our experience with T-CAR, I think that our algorithm is completely changed.
I may sum up that the skilled people may solve the problem. Intelligent people may prevent the problem.
Well, thank you for that. But
that has to be the last word, doesn't it?
That wasn't that.
Okay, before we conclude the
Lady?
session, for everybody who's interested, I think there is a great hands-on session after lunch, if you want to see it. I think it starts at 13:35, something like that. If you still want to sign up, come to room 2, and then I'll leave the final word to Alison to conclude and thank everybody.
Thank you. We had a great session, everybody.